this computer. And as you know, today we will continue with the chapter 7, 8, and 9, and the last content will be on the infections and the different types of reactions and hypersensitivity reactions and the 4 different types. Okay, so I'm trying to share the slides with you. Can you see the PowerPoint slides? The one says infection on the top.
Mm-hmm.
All right, so this is where we left our, stop at this slide. I'm maximizing the, I won't be able to see everybody on. That's fine. All right, so we will begin today with, with the infection and the HIV/AIDS was one of the infectious disease. I mean the infectious and the immune system diseases that we covered, or it was covered as a student presentation last week, right? Yeah, last week on the 29th for section 1. So I don't have to repeat. It's just a highlight, just in a couple of, few minutes, go over the HIV when we get to that slide. So first, this chapter talks about the infection and when it says normal flora, for example, we have with microorganisms, it's not always, like harmful microorganisms, as you learned, and probably have this or learned it from other courses like biology or micro, that some of these microorganisms are beneficial for to the human being. And one example of that would be the normal flora that is present mostly in the GI system. And the new trend now for, I would say that all practitioners now, they are doing great job on this, is to prescribe, once you put the patient on broad spectrum antibiotic, knowing that this antibiotic is going to kill and eradicate the good bacteria in our GI system, we call it flora, that at the same time we prescribe broad spectrum antibiotics, especially the intravenous, that you have to also put the patient on some type of a probiotic. When you purchase that yogurt from from the supermarket, or that this is a form of probiotic. We have something called BACID, Acidophilus lactobacillus, and nowadays you have we'll see these like Activa or these kind of commercials or commercial like products on the market, which includes the probiotic. And so either your patient will take the probiotics in terms of like tablets, like medication, and you can get that over the counter, the OTC over the counter med, or just to replace it with just the dietary kind of product, like yogurt will be in like one thing. So anyways, it's just to explain the point behind that the antibiotics, because especially when it's broad spectrum, it will kill some like beneficial or good bacteria. So that's an example that our body also include beneficial and good bacteria. So so previous to the advent of using the probiotics with antibiotics, patients used to develop problems. See all that C. diff, patients develop the C. diff from, for that reason, or due to the use of broad spectrum antibiotic, which has gone to eradicate all the flora, the good bacteria, and then the patient develop infections, which made, because when you kill all the good, the broad spectrum antibiotic, when it kills the good bacteria, is going to allow for other bacteria to, become active, which, we call this opportunistic infections, or these organisms not harmful when the immune system is competent. But when the immune system is incompetent and is weak, that's when these organisms or microorganisms going to become harmful. So these microorganisms, normally they are, they have a mutual kind of, relationship with our body. They benefit, we benefit from them. But at some point when our immune system becomes incompetent, immunosuppressed, that's when these microorganisms become active and no longer beneficial. They become harmful. The stages of the infection that can, would apply to most of the infections, colonization, invasion, multiplication, and then the spread. And that applies to almost all microorganisms, the viruses down to the protozoa, the fungal infections, bacterial, all of them. And then we have factors in which the infection by a pathogen is influenced by these factors. Like the mechanism of action, the infectivity, which is the ability of the pathogen to invade and multiply in the individual. Pathogenicity, virulence. Like nowadays, we talk about the virulence of the COVID-19. The virulence of COVID-19 after May of last year, it's not strong as it was before May. The severity of people, of the signs and symptoms, and the intensity of these symptoms and manifestations of the disease, and the life-threatening, manifestations that are not quite the same as it was before May of last year. So that's kind of example of the virulence, which is the potency of the pathogen measured in terms of numbers of microorganisms of its or its toxins to kill the host. And here we have we can measure it. The virulence can be measured like the colonies, and when we grow the bacteria in the in the lab. And let's say like culture, when you culture the secretion or drainage or blood specimen or urine specimen, and you send it for culture, that's, you're looking for the virulence and see the potency of the organism. Immunogenicity and the toxigenicity. All of these are factors that will govern or will influence the the extent and the intensity of the infection. Once the patients develop bacteremia, that's is defined as, or septicemia, we will say that patient became septic. So septicemia or septic and bacteremia, that's when the bacteria and the microorganism enters the bloodstream. So that will infect the bloodstream, and then the patient become septic, or what is called bacteremia. When we talk about the pathogen defense mechanisms, the pathogen itself also has some defense mechanisms to protect itself. And we have seen also this in the last few weeks. When we hear about the new mutations of the COVID-19, for example. So these new variations and new mutations, these are the adaptations that the virus is attempting to change in their own genetic makeup to protect themselves from the host or from being being attacked, being defeated, being eradicated. So these changes, that same thing with the flu. We have something called antigenetic drift and something called antigenetic shift. These are some of the antigenic variations, or what is called the antigenic mutations, or the gene switching. All these are different ways or mechanisms that the microorganisms attempts to defend themselves, as what is called pathogenic defense mechanisms. And you will find also the difference when it comes to gram-negative versus gram-positive bacteria. Each one has, or negative versus positive, they have the cell's membrane has a different thickness, and the composition also of the cell membrane is different. So the gram-negative, the gram-positive bacteria, it has a thick layer of the peptidoglycan, which is on the left right here. And then the right one here, this one is the gram-negative bacteria. It has the same thickness of that layer, but also it has an outer layer too. So it's have an additional layer on the top of that thick layer. So which makes the gram-negative bacteria more difficult than the positive gram-positive bacteria to treat. So that's one of the reasons why gram-negative bacteria is more difficult than the gram-negative to treat with antibiotics. There are antibiotics, but it's just more difficult than the positive ones. So viral replication, when we said virion, or VIRION, virion, it includes the virus, which is the particle with its viral genome, which either it's RNA or DNA, and include also its protein coat. So that's virion, includes everything, the virus particle with its viral genome, either RNA or DNA, and its protein coat. The virus, as we know, it has to enter the cell to become active. So the virus, it's not active until it injects itself into the cell and enters the cell. So that applies also to the HIV virus as well. The HIV, as long as it's outside of the cell, it doesn't do any harm. Once it injects itself into the virus, then it becomes harmful, and it will infect the cell, and then the cell will do something called budding, and then that will cell division, and that will result in producing more infected cells. So the virus replicates in the nucleus. Replication takes place in the nucleus. And we know the clinical manifestations of the infectious disease. Mostly, all patients with any infection will have a fever. And that's, we explained this last week, because of the exogenous pyrogenes and the endogenous pyrogenes, especially the lipopolysaccharide proteins in which the bacteria produces. Now, the countermeasures, how to protect our body from these microorganisms, mostly bacteria and viral, same thing, that we will include two main strategies. The first one is the health promotion, which is vaccination. The second level would be the antimicrobial drugs. And in pharmacology, you will learn about the different mechanisms under the antimicrobial, how each group or classification of drugs will work in terms of the mechanism of action. Some medications or antimicrobial or antibiotics will inhibit the synthesis of the cell wall. Other antimicrobials, antibiotics will damage the cytoplasmic membrane or inhibit protein synthesis. So these are different mechanisms, which is mechanism of action of the drugs. So in pharmacology, cephalosporin, Rocephin, for example, it will inhibit the synthesis of the cell wall. So that will be like an example of the antibiotic or the mechanism of the antibiotic that will treat specific type of infections. Now, before we get to the congenital versus the acquired immunodeficiency, there is something we all always hear about, the resistance, right? The multiple resistance microorganisms. So why have multiple resistant microorganisms appeared? Why would you see a resistance and the microorganism is not active anymore? What could be the reasons?
They mutate.
I'm sorry, the mutations?
Yeah.
Right. So that will be some related, would relate to, this to the mutations that the bacteria will go through or undergo as they attempt to change, the genetic makeup, and that will protect themselves and become resistant. So when we send the specimen, blood, urine, drainage, or or wound drainage, or secretions, or any type of CSF, or any type of fluid, bodily fluid, for culture and sensitivity, we call it CNS, culture and sensitivity, which is CNS. When you send it for culture, you're looking for, first of all, you want to identify what type of organism is causing or is present, if there is any, in that blood or specimen, or fluid or CSF or urine, or you want to identify the organisms, if there is any. So sometimes you have like more microorganism number one, number two, and you have one or more or none. So you want to see if the culture is positive or negative. It's positive, which means there is a microorganism and has to be identified. It takes up to for final results for the culture to have the final results. It takes about like 3 to 4 days. You will still keep receiving preliminary, results, the first day, second day, but the final results until the final growth of bacteria had shown, if there is any in the specimen, it takes about max of 3 or 4 days. So the pathogen or the microorganism has been identified. This is number one. So we will select there is E. coli. Second, you need to know how virulent is this bacteria or this microorganism in that specimen. So it will give us it's something called CFU. Which is percentage in terms of we have we'll give you let's say more than 50% CFUs in DC, or more than 100,000, or less than 50,000. So it'll give you a specific number, which is, in other words, that it can be translated into virulence, if the bacteria is virulent or non-virulent. So why there is resistance sometimes, and then the last layer or the last result, or as we analyze the report from culture from the CNS, first identify, it will identify the microorganism. It will give you some type of the virulence, the percentage or the number of CFUs, the cell follicle organism. And also it will provide you with what type of antibiotic that the list of antibiotics that will be good for this patient, in which that this microorganism will be will react in other words, will be like, this will be effective for this microorganism, or if the microorganism will be resistant. So the why there is resistance, going back to the question why there is resistance, in addition to what we have said about the mutations and and variations, also the multiple use of antibiotics. There are, overseas here we have in the U.S. we have a 100% control on the use of antibiotics. You cannot use antibiotics until you go to the prescriber, and they will prescribe antibiotics, and they will get it from the pharmacy. Other countries, they have like no control on this, and they will take as they go to the pharmacy, get the antibiotic as buying the OTC medication, over the counter medication, as if you are like buying candy. So, which means that the frequent use of antibiotic, and sometimes they use it for viral infections, like upper respiratory viral infections, they will automatically just go to the pharmacy and will get a antibiotic for the kid. And this is not a good practice. Here in the U.S., we have a good control on the prescription and the use and the frequency of using the public use of antibiotics. The problem is when there is no control. So the resistance would result from the multiple use of an uncontrolled use of antibiotic. And then eventually the microorganism become resistant to that specific bacteria, to that specific, infection, antibiotic. The bacteria become resistant to that antibiotic. So the resistance would result from the overuse of antibiotic, which can lead to the destruction of the normal flora, which result in sometimes called C. diff, for example.
Professor, can I ask a
Yes.
question?
Yes.
You hear sometimes that the use of antibiotics in animal feed and meat production also also creates more of this problem. Is that true?
Yes, absolutely. Yes. Yeah, it has an effect, animal feed, or we know there is minimal control on, well, there is some control, but on the other sources, and like food, dietary, like food product, and and in fertilizers, and all these. But we will get to this in the what is called xenobiotic, which is, we'll get to that in the cancer. So it's even, the problem is, I would say, exceeds the resistance to the antibiotic, but also it's adds more, risk for, cancer development. So we'll talk about the cancer, next, on Friday, on chapter, that talks about the cancer and neoplasm, in which that these are one of the major, I would say, the factors called xenobiotics, that we get that from, as we from in milk and dairy products, and meat, and different resources, we get that the market. So that's why most people now go into organic, and hope that organic is organic, and that's another, like sometimes you don't even rely, like trust the sources too. So again, it's multifaceted kind of problem, and needs a lot of regulation and more control too. But it's more relates to, can cause resistance, but also it's more dangerous for for the that the human body can develop cancer from this. So which is, we'll get to that on Friday, talking more about that, because we have a lot of examples about about these, what you have mentioned, Amy, about the these food products, and how it's how it's eggs and milk and dairy products and meat, and it's big, they use these antibiotics, and then we will get some part of it. And anyways, so back to the immune deficiency, we have, when it's primary immune deficiency, then it's congenital. When it's secondary, will be acquired immune deficiency, such as HIV/AIDS disease. And that can affect both T cells, T lymphocytes, and B lymphocytes. Excuse me. And then also we have combined deficiencies as well. Now, the HIV infection, we said that we um, uh, the study, I mean, the case study or the presentation done last week covered the HIV. I'm just going to highlight a few things that the difference between the acute phase and the chronic phase. And in the acute phase, it says here weeks to months. It depends on the, which is, we call this is a window period. So the antibody against the HIV infection with blood products, it takes about 4 to 6 weeks, or I mean 4 to 7 weeks. But from the sexual transmission, it takes longer, about 6 to 14 months. So the initial infection, it's called viremia. And patients who are infected, HIV positive, patients or infected with HIV, they will be hope that they will be compliant with their visits to, the frequent visits to the HIV clinic, and they will run two things for them. Every time, every 3 months or 6 months, visit, they will do viral load and see how is this viremia, how is the virus, present? Is it a lot, strong, weak, and how much that, which is the virulence of the virus of the disease, which is viral load, how much of that virus is present, and then they will do a CD4 count. So the T helper cells, the CD4, which is the target of the HIV virus, the attack will go to the CD4. So the CD4 is the target for the virus, and the virus would attack the CD4, which is the T helper cells. So which means that the CD4 will be reduced or decreased in count. So normally we're supposed to have a CD4 to CD8 ratio of 1 to 2. If we have 1,000 CD4 count, then CD8 would be around 500. Normal CD4 for healthy people who hasn't been infected with HIV, that runs between or goes between 600 up to 1,200. So the ratio again for healthy, non-infected will be 1 to 2, 2 CD4 to 1 CD8. And we know that CD8 from last week, we said that the CD8 is, is the T suppressor cells. These cells are which attempts to control the immune response and prevent it from being exaggerated. So that will prevent the reaction or immune response becomes attacking our own cells. Otherwise, if we have lots of CD8, then, or they are very active, that will result in autoimmune disease because they're going to attack our own cells. Remember that we said that the immune system, the basic principle is the able to identify non-self cells as non-self, so they will attack them. Otherwise, if our immune system will identify or recognize our own cells as non-self, they will attack our own cells, right? So that will result in autoimmune disease. So CD8 is one of the reasons we have CD8 is suppressor cells. So it will control the immune response and prevent that response from becoming exaggerated. So we have 2-to-1 ratio of CD4 to CD8. In patients with HIV, we have the reversed sequence, or the numbers are, or ratio is reversed to no longer is 2-to-1, because the CD4 will be the target for the HIV virus. So the patients with HIV/AIDS, we expect that they won't be able to maintain the CD4 within normal ranges, but at least it's to a point that's not going to elicit or result in opportunistic infections. So first of all, that patients, as long as they maintain between 450 or above, that's good. At least will protect them from becoming infected with other diseases. And once it's less than 400, they will become immunocompromised. But less than 200, the patient will be at risk for opportunistic infections. like PCP, pneumocystis carinii pneumonia, Kaposi sarcoma, wasting syndrome, cachexia. They will have the cytomegalovirus, CMV. All of these are examples of the opportunistic infections. So once they had developed this, all, let's say like, a year or 2 or 10 years from now. So now we said, right now it's the acute phase. Once they have developed, one of these opportunistic infections, then that will be the delayed chronic phase. Some patients, they stay in that acute phase and never progress, or progress or go to the chronic phase because they are compliant with the medications, with the antiretroviral meds. So one of the criteria to identify the patient they have entered the chronic delayed phase is once they develop one of these opportunistic infections that I mentioned earlier, in addition to other criteria. But we know it's just to know that conceptually, that patients they will once they're infected, that's the acute phase, and then if they develop any of these criteria along the way, that they will be that is chronic delayed phase. And I have seen patients in the hospital with HIV that in their 60s and 70s, and they are just in their chart HIV positive only. They never went to AIDS. So when we say AIDS, that's the chronic one. That's the delayed phase. So the early phase, once they're acute affected or infected with the virus, that is HIV positive. But if the patient later on develop any of these opportunistic infections or other criteria like wasting syndrome, another criteria for AIDS. So we will say that patient had deteriorated to the late or delayed and chronic phase, which is called AIDS. So HIV positive versus AIDS, that's the difference between them. Acute versus chronic. And the key to for the management of HIV/AIDS is the compliance with ERT meds, antiretroviral meds, and most I would say a good number of patients they are non-compliant for many reasons. The main reason is the side effects associated with the medications, especially GI symptoms. Given that patient will be on 3, 4, or 5 medications daily, 3, 4 times a day, it's a lot of meds taken to treat HIV, and eventually patients will give up and just stop taking the meds, and that's non-compliance because of most, I would say, GI side effects or symptoms or manifestations. And there's other reasons that one of them also is the health literacy, which is that some of the patients didn't know, they have no idea, no clue that these meds are covered completely by the government. So it's so if they have no insurance, or if they do have or don't have any insurance, health insurance, they still can receive these meds for free, but they have to commit going to the HIV/AIDS clinic, because that's another problem that may encounter them. If they don't go frequently to the HIV/AIDS clinic, then they will miss that, because that's the only place in which they will be tested for the viral load, and for the CD4 count, and to receive or to renew and the prescription for the medications or for the meds, for the HIV meds.
Professor, I have a question.
Yes. Yeah.
The antiretrovirus meds, that's what they talk about when they talk about the cocktail, like that people go on after but it says that the initial infection is viremia, and that's infectious to others. But that's just one. I mean, once they go on the cocktail, they're not infectious anymore. Is that correct?
They are infectious. They're infectious because the virus is still there. It's present.
I thought that you could get to a point where the viral load was so low that you would,
All right.
almost like having diabetes, but you still have to take precautions until you get to there.
Yes. Yeah, the infection, because given that, we have specific criteria for the, for the infectious, or HIV positive patient to infect others. The
So-
viral load, yeah, the viral load will decline to a very low level when they are on ARTs, the cocktail and the ARTs. That level doesn't go to zero, but there is a virus, right? The virus is present. Now, as we know, there are a lot of misconceptions about, we hear about the misconceptions about the HIV transmission. The transmission is still there, will be to the last day of their life, but the transmission is consistent, or it's related to many factors. One of the factors is the length of the exposure, the intensity of the exposure, and which means that it doesn't mean anyone who will be in contact for with that person will be infected. It depends on the intensity, on the length, on the and the viral load. But we always have to take the precautions. That's why. So we don't want to take the chance that there is the viral load is low, and then the exposure is gonna be a couple of minutes, but still there is a risk all the time.
And what about once they develop into AIDS? Will those won't work anymore? Like they just have to deal with the AIDS symptoms as they come up?
No, they can still be on these ERTs, but at least they can. So we can reduce the intensity of the symptoms. We can reduce the intensity. We can reduce the frequency of the exacerbation of the disease process. We can for life expectancy. So I think we don't want to say that once the patient has developed the AIDS, then they have to stop taking the meds. But I have seen patients with just HIV positive and never entered the phase of chronic
Awesome.
phase. Yeah.
And
yeah.
what was, I'm so sorry, one more question. What was AZT? That was what they used to give them? Do you remember that? It was like in the early years, it was you would go on AZT.
Oh, that's azathiopran. That's the azathiopran is the it's an immunosuppressive agent. I'm
Oh,
not sure why they will give AZT.
it was a long time ago.
Yeah.
Elegant.
So okay. All right. So the pathophysiology, as we know that the virus attacks and targets the CD4 cells, the T lymphocytes of T helper cells. And again, this the magic number here is that once the CD4 count is less than 200, then the patient is considered as having the severe immune problems, or develop severe immune deficiencies, and then patient will be prone to develop the opportunistic infections. And this is an example of a patient this is just a case study of a patient with infectious disease, and this one is a UTI. And this is the explain what I was trying to I was talking about, which is the CNS, which is that when you send the specimen for urine, let's say this one is a urine specimen, and you send it to the lab, and then you requested a CNS, and it has to be a sterile, right? You collect it via sterile technique, or you have to exercise asepsis, which is a sterile technique, and the results would be like this. So with the CNS for urine, I would say that once you see leukocyte esteroids and nitrites are positive, that's an indication. This one isn't only just as urinalysis. This is not CNS. Sorry, this is just urine analysis, a UA we call it. Once you see in the urine analysis UA leukocyte esteroids, which means that there is a bacteria, and these are the remnants, or the the resultant enzymes of the bacteria, and the nitrites as well. These two, when they are present and they are positive, 1 or 2 or 3, or if they are present in the urine analysis, then that's an indication that there is bacteria and there is a UTI, urinary tract infection. And then once I see this, I would request a CNS, because sometimes practitioners do not want to request a CNS, which is culture for the urine, until they see these leukocyte histories and nitrites, and then they'll request a CNS culture for certain reasons. But the CNS, again, that will provide us with the identifying if there is any bacteria and what type, and will give us also the amount and the virulence of the bacteria in terms of, like, how many thousands of CFUs of the E. coli and so forth. So that's CNS. And I don't want to go to the questions here because that will take some time from our lecture. So I can post the answers on Blackboard, so all you have access to the answers. So let's go to a different topic, which is the immune reactions. And the immune reactions, which is called here the hypersensitivity reactions. And we have 4 different types of hypersensitivity reactions. They are inappropriate immune responses. Inappropriate immune responses, we have 4 different types. When the immune response is exaggerated against, like, allergen or antigen. Let's say, like, people are asthmatic, or have asthma, or being diagnosed with asthma, and once they are exposed to the irritants, to the asthmatic allergen, or to the asthmatic antigen, or what is called the triggering factors. Let's say that cold weather, sometimes for asthmatic, we allergic to, asthmatic, or elicit the asthma attack once they are exposed to the cold weather, for example. That's the triggering factor. There's we will go over the asthma in adult health too. We'll identify all these triggering factors. It can be perfumes, it can be animal dander, or cold weather, or certain type of foods, or aspirin, or NSAIDs, or we have lots of factors that may trigger the asthmatic attack. So this is called an antigen, or the environmental allergen. Whereas some people, they are allergic to environment, like seasonal allergy, for example. That's another form or type of the exaggerated against environmental antigens. So that's an allergy. Allergy can be in response to food products, allergy in response to certain medications, allergy to certain type of chemical products, allergy to certain factors, environmental factors. So that's the allergy. And it can, and each one of these classifications, or each type of categories, it can it can be explained in 4 different levels, like type 1, 2, 3, and 4. Like type 1 under the allergy, it's always, type 1 is always going to be IgE mediated. And I will go over the IgE mediated because that's the most common one. Patients who are allergic to, let's say, seasonal allergy due to pollens, exposure to the pollens in the spring, right? They will develop that allergy attack. That is IgE mediated. It's called type 1, hypersensitivity. Type 2, which is hemolysis and drug allergies, like patients who are allergic to penicillin. When they develop the allergy, that is type 2, because it's tissue specific. For type, let's say, type 3, which is like patients who are who have the wheat allergy, like gluten, allergic to gluten, right? And then they will eat gluten-free, right, diet, and so that's a wheat allergy. So that is type 3. It's called also immune complex type of allergy. So the mechanism for each one, that's why we classify it as type 1, type 2, type 3, and 4, because each one has a specific mechanism and different mechanism. The first type 1 is IgE mediated, type 2 is tissue specific, type 3 is immune complex. There is immune complex. And then the last one, which is a type 4, it's called also delayed allergic reaction or delayed allergy, because it's a cell mediated. The first three, type 1, 2, and 3, what involved in within the allergic reaction is the antibodies, the immunoglobulins. They are part of the type 1, 2, and 3. But type 4 doesn't include any antibodies or immunoglobulins. It's a cell mediated. An example of this is the poison ivy allergy is one of them. Or when you inject a PPD test, I mean, the PP for PPD test, when you do the test for the TB, the PPD test, that's a cell mediated allergic reaction. And it delayed, we say delayed reaction, because when you do the PPD, you don't read it right away. You will wait about 2 to 3 days, between 48 to 72 hours, to anticipate any reaction to that. So that cell mediated, it takes time. Cell mediated type 4, it's a delayed reaction, and it doesn't occur right away. Type 1, 2, and 3, it might, it could take minutes, or hours to develop. So we explained the allergic reactions or allergies in terms of exaggerated against environmental antigens in type 1, 2, 3, and 4. You apply not exactly the same, but very very similar kind of explanation to when their patient immune system are going to attack its own cells, and when it develops the autoimmunity or autoimmune disease. So that's when the misdirected, when the reaction is misdirected against the host own cells, becomes an autoimmune disease. Patients with SLE, for example, systemic lupus erythematosus, SLE, it's a type 3 immune complex, because there is an antigen antibody complex that is going to destroy most of the of the systems, mostly the kidneys and renal system, for example. So this is like SLE. It's a type of reaction of type 3 because it's an immune complex. The autoimmune thrombocytopenia, which is type 2. Some, people are like born with an autoimmune thrombocytopenia, or when they develop the thrombocytopenia in response to certain medications. You will learn about this in pharmacology, about something called HIT, the HIT, heparin-induced thrombocytopenia. So the heparin will induce this reaction and result in autoimmune thrombocytopenia, which is the decrease in the number of the platelet count. Platelet count will drop in response to the heparin intravenous injection. So not all patients, there are small percentage of population, they have this autoimmune tendency. It's an autoimmune thrombocytopenia in response to the heparin, for example. So because
isn't heparin a diabetes medicine? Isn't it a form of, isn't it insulin?
No, heparin is a anticoagulant medication to prevent. Heparin is to prevent blood clots. Anticoagulant medication to prevent blood clots. So as just an example of how heparin could result in a thrombocytopenia, it's called HIT, the HIT, heparin-induced thrombocytopenia. So when the patient develops this type of autoimmune disease, their own immune system is going to target the platelet count, platelet cells, and destroy these cells. And all of a sudden, you will see that when you put the patient on this medication, for example, you will see that the patient, like within like hours or a day, the patient's platelet count will drop to less than 140,000, and then the patient will be at risk for bleeding. So you gave this patient a heparin to prevent blood clots or to stop the blood clotting, and then eventually the patient will develop the bleeding. This is an example of how the autoimmune thrombocytopenia, as classified as type 2, and is tissue specific, and the HIT is an example of that. You can have an example of type 3. We said it's SLE, lupus, and we have another one, which is the type 4. An example of that would be a form of hyperthyroidism, and eventually the patient will become hypothyroid, but it's called Hashimoto's thyroiditis. And this one is type 4, which is E-cell mediated. So this is an autoimmune disease, autoimmunity. Our own immune system is going to target its own cells and destroy them. We don't have examples here of type 1, given that it's an autoimmunity, and because it's an IgE, so we don't have an example of that. We have the third one, which is the alloimmunity. The difference between the autoimmunity and the alloimmunity is that in the alloimmunity, our cells or our immune system will target cells from outside, like exogenous. So it says directed against blood transfusion transplants. So let's say that in a patient who has survived a lung transplant, once they develop the rejection, graft rejection, that is a delayed or cell-mediated, that's type 4. An example of alloimmunity. So the difference between autoimmunity and alloimmunity, our own immune system will target its own cells. So everything inside the body. Alloimmunity, it's always going to be the immune system targeting something that we receive from outside. Blood transfusion is coming, right? Exogenous. So something we will receive it. Then our immune system will target it. Or graft, which is transplant, or graft, skin graft. If the skin graft is a form of the transplant, lung transplant, or heart transplant, or any organ has been transplanted and then the immune system rejected it, that is a form, type 4, and that is a graft rejection, and that is alloimmunity. So that's the difference between autoimmunity and the alloimmunity. An example of the alloimmunity as of type 2, which is tissue specific, like a hemolytic disease of the newborn. And I will give an example of that right after I mentioned the fourth type, which is the immune deficiency, which is insufficient to protect the host, which is when our body is immunodeficient. So that's either due to what could be the reasons our immune system is not competent, which is immunodeficiency, or we call it immunosuppression.
Cancer treatment?
Cancer treatment, HIV, by the virus itself. Stress will affect it, but not to the point become immunodeficient. It become immunodeficient also because of the induced by the medications. We induce that immunodeficiency become immunosuppressant because we want to, right? So that's induced, intended to immunodeficiency. We need the immune system not to be strong enough. We want the immune system to be suppressed. It's called immunosuppressant medications. And these meds would be prescribed for who? Who would receive them? Immunosuppressant meds.
People with autoimmune diseases?
No. Autoimmune disease, I'm sorry, the autoimmune disease, yes, that would be one of them. Another type of patients who need them, because we don't want the immune system to reject the transplanted organ, right?
Yeah.
So once we have, successful, or patient with a successful surgery of, let's say, like lung transplant or kidney transplant, skin graft, we don't want the immune system to reject this foreign organ. So the patient would be on lifelong immunosuppressive agents, right? Is this clear? Patient would be on lifelong immunosuppressive medications, three, sometimes two or three or four even meds will be, taken every day, lifelong, to prevent. So this is like induced, intended to to suppress the immune system, so it won't reject the transplanted organ. So that is insufficient to protect the host. That's immunodeficiency. But other, the disease, in terms of diseases, HIV, AIDS, and all the diseases that affect autoimmune disease, and is another form too. We have like T cells, B cells, or combined T and B cell deficiencies. They are specific to. We have decline congenital. Some of these are congenital, like T cells or B cells deficiencies, which would result in immunodeficiency. The classification I did, went over the different types of deficiencies, and I'm sorry, the sensitivities like type 1, type 2, 3, and 4. I just want to explain the when it says hemolytic disease of the newborn, which is type 2, tissue specific. See how the immune disease, I'm trying just stop sharing and just go back to the whiteboard. If I'll be able to try to explain the concept behind or about this hemolytic disease of the newborn. So let's put here the which is going to be here something called the baby, when the baby is born, will have something called hemo plastosis fetalis. And that's very dangerous for the baby. And this is when let's say that the baby is RH, so it has to do with the RH, positive or negative blood group, and we'll go, we'll explain the blood group towards the end of the lecture about the A, B, and O, what it means in terms of the positive versus negative, and the antigens and the antibodies. So we'll explain that towards the end. But this is an example of a mother who's pregnant with a baby whose blood type is could be any blood group, but the RH is positive, but the mother is negative. So given that there is the baby's blood is RH is positive, then the immune system of the mother is going to attack the baby's RBCs because it's the positive RH. So the RH positive means here this is like an antigen will be attacked by the mother's blood or immune system. So the mother immune system is going to attack the babies, and that will result in sometimes a stillbirth, like in the baby will die during pregnancy, and that will be ended in the early stages, or the trimester, first, second trimester, or sometimes the baby will born with with severe anemia called hemoplastosis fetalis. But this is an example of how is the immune system. This is um, an example of type 2 tissue specific called hemolytic disease of the newborn. So going back to the PowerPoint slides, type 1 through type 4. Any questions so far? So I know there's a lot of information. I just included here lots of examples about the 4 different types of sensitivity. And I will just explain the type 1 because this is the most of the scenarios and cases you'll have, will be of type 1. the frequency of patients you will encounter will be like patients with different types of allergies and asthma, the seasonal allergies and food related or medication related that will be of IgE mediated. So the IgE type 1, which is an IgE mediated, that's immunoglobulin type E. And if you recall from last week when we talk about the IgE as an immunoglobulin type E, it would elicit the allergic reaction. First of all, we have to be exposed to it. It consists of like two phases. The first time you will be exposed to the allergen, can be anything, can be any type of allergen. Your immune system first will be sensitized to the allergen. And anytime, right after this first exposure, anytime your body is going to, or immune system is going to be exposed to the same allergen, because it became sensitized, and I'll explain what do we mean by sensitized, then your immune system will elicit the allergic reaction. And the allergic reaction includes all these, could be all or some of them. It depends on the type of allergen, depends on the antigen or the type of antigen. So runny nose, redness of the eyes, right? All of these are, sometimes even GI symptoms, nausea, vomiting, and it could result on a severe allergic reaction, which is anaphylactic shock, anaphylaxis, skin, like changes to the skin, like urticaria or red pinpoint, like rashes or skin change. So all these are anticipated manifestations of the allergic reaction, or respiratory too. Secretions from bronchioles and bronchial tree. These secretions will result in respiratory problems, bronchospasm, angioedema, rhinitis, asthma. So all of these are manifestations. Some or all will result from the allergic reaction. Now, first of all, so this will be on secondary exposure. Anytime we get closer, like exposed and closer to this and exposed to this antigen, the same antigen will be, which will, we are sensitized to, we will elicit, or our immune system will elicit the immune reaction. Which is in this case, which is the allergy. So the type 1, it's the activation of, so first of all, become sensitized. That's when our body first exposure or immune system, which is the mast, if you recall, the mast cell will have the IgE attached to the mast cell, and the IgE antibodies attached to the mast cell. So we have the antibodies are attached to the mast cell, which is the IgE type antibodies. So at this point, the mast cell became sensitized. In other words, that anytime in the second exposure, anytime we are close, or exposed to the same allergen, this one, we have a mast cell that became sensitized with antibodies, IgE attached to it. It will be stimulated anytime we'll get close, we'll be exposed to the same allergen. And then the mast, the chemical mediators, mostly cytokines of like histamine, for example, one of them, right? Remember the histamine will be released and cause all these problems, in addition to other chemical mediators too. But histamine will be the major one. So this is the IgE cell-mediated, IgE mediated reaction, which is allergic reaction. And that could result in anaphylaxis. Atopic dermatitis will be another example of that too. Type 2, which is called cytotoxic or cytolytic reaction, which is tissue specific. And we give some examples of that, like reactions to drugs, if we are allergic to certain medications, that would result in this type of reaction. Blood transfusion, any reaction blood transfusion, it's type 2. erythroplastosis fetalis, like the one I explained, the RH incompatibility. The mother's blood is negative, RH is negative, and the baby's blood from the father is RH positive, would result in a severe anemia or sometimes even stillbirth. Type 3, which is the immune complex reaction. And an example of this one would be the systemic lupus, which is an autoimmune disease. And glomerulonephritis, also another form, because the glomerulonephritis, we'll cover this under the renal system, in which that there will be an antigen antibody complex is going to attack the basement membrane and the nephrons and destroy the kidneys, as an autoimmune disease called glomerulonephritis. We call it AGN, acute glomerulonephritis, AGN. And then the last one, which is type 4, which is the delayed reaction. And this one, an example of that would be the graft or transplanted graft rejection. The PPD test, another one. Hashimoto's thyroiditis. Poison ivy is also delayed reaction. Contact dermatitis. It shows here the first exposure and second exposure. Autoimmunity. Which is, in other words, that it will result in autoimmune disease. So before we get to the autoimmunity, just to mention that the contact dermatitis, it's a form of delayed reaction, which is type 4, cell mediated. Again, the type 1, 2, and 3, all three different types of reactions, type 1, 2, and 3, they will involve the the immune globulin antibodies as part of the disease process or the reaction. Type 4, it's a cell mediated. It doesn't include any immunoglobulins or antibodies. So it's no antibody production and cell mediated or delayed reaction, type 4. The tissue damage will occur when the T cells attack the antigen or the T helper 1 cells release the chemical mediators or what is called the cytokines. And reaction of type 4 takes time. That's why we call it delayed. It takes about 24 to 48 hours to be elicited or to occur. And we give some examples of that. And so the contact dermatitis, that's an example of type 4, of the delayed hypersensitivity reaction, which will lead to the vesicles and scaling of the site of the contact. And who would be affected by this? An example of contact dermatitis, examples from clinical sites or from your experience?
Latex allergy?
Absolutely, yes. And it can be any material that your body is allergic to. Sometimes, people wearing jewelry or rings or certain types of, so the chemical component or composition of the metal or of the jewelry that your skin is allergic to. So it's very individualized when it comes to the allergies to certain things or materials, I mean. So autoimmunity, which is, we call it familial disease because there is a familial tendency and predisposition to the disease. given the genetic predisposition. We said that the autoimmune disease, it's when there is a breakdown of tolerance, so which means that our immune system is non-tolerant to our own cells. Then that's when the autoimmune disease is going to elicit the immune response and attack its own cells. And SLE is an example of that. And the alloimmunity, which is we said examples of that would be transfusion reactions. So the immune system reacts with antigens on the tissue of other genetically dissimilar members of the same species. An example of this one would be the individual blood type A will have A antigens and anti-B antibodies, and I'll explain that in a minute. The antibodies circulating in the blood are of IgM type. So the type of the immunoglobulins or the antibodies is of type M, IgM. The antibodies circulating in the blood are of IgM. The universal donors would be, who would be the universal donor? Of type, blood group type?
Blood, O.
O. O blood type is the universal donors, and then the AB blood type are the universal recipients. So I explained how the baby who has an Rh positive, the mother's blood's gone or immune system will react, right? And destroy the baby's RBCs, red blood cells, and then the baby will, right, develop the hemoplasmosis fetalis, which is severe anemia due to the destroyed RBCs in response to that incompatibility of Rh, what is called the Rh incompatibility. So and you can add to that also alloimmunity transplanted rejection or transplant rejection. Now, let's focus on, as we try to explain the antigen versus antibodies and how patients with certain types of blood groups supposed to receive the correct blood group, otherwise they develop reaction or the alloimmunity. So here we call it alloimmunity. It's not autoimmunity because our immune system will elicit or react to exogenous source. Blood is being received, right? So it's no longer against our own cells. It's it's against the external sources. So blood transfusion here, first of all, the blood type, the blood type A, see here, all these proteins on the top of the cell surface is called antigens. These are the antigens. And the antibodies, once they attach to the antigens, they will elicit a problem. They will elicit the complex, and then that will result in the immune reaction. So the patient with or healthy or people who are classified or known to have a blood group, they have two things. Everyone should have except for AB. They don't have antibodies, and O, they don't have antigens. So A and B, they have both. They have antigen and antibodies. So blood group A, they have antigen of type A, and their body, this is in the serum, this is the antibodies, IgEs, immunoglobulins floating in the bloodstream in the plasma. They have anti-B antibodies. So patient with group A, whose blood group or type A, their body, their RBCs, this is the erythrocyte, this is the RBCs, red blood cells. It should have A antigen or antigen type A on the cell surface And then in the plasma, what's floating in the plasma, they have anti-B antibodies. So what would let's just give a scenario of what would happen if the patient with blood type A received blood transfusion, a unit of this type, of B type.
It'll get rejected.
How? Can you explain why the patient will elicit or will develop, the immune system will attack and develop a reaction or immune reaction or response?
Because of antigen A antibody?
Because there is an antibody, anti-B antibody, and the patient and the patient is receiving this RBC with this antigen, with the antigen B. So this patient already has this antibody, is going to attack it because B will go with B. The antibody will attach to the antigen because it's like a lock and key. B goes with B, A will go with A. And once the lock and key attached, then that will elicit the destruction of the RBCs. And that will result, which is the immune reaction or the immune response, which is the destruction of the RBCs, which is hemolysis. That's why the patient's blood, hemoglobin will drop significantly to low levels because of the hemolysis of the RBCs. So if this antibody attached to this antigen, it will result in destruction or the activation of the immune response and the destruction of the RBCs. If this antibody attached to this antigen, also it will, because that's anti-A antibody, and this is antigen A. So it fits. A goes with A, B goes with B. So, which means that this patient should only receive, which blood group would be great for blood type A, and can safely be administered and can be transfused to the patient. This one we said no, because this patient is going to receive this blood, which will have anti-A antibody, which will destroy the RBC. Can the patient receive AB?
Yeah.
Because no antibodies, right? Yeah. Can they receive O?
No.
Right. Mm-hmm. Any questions so far about the blood groups?
So, O blood type doesn't have antigen A or B. It has none, no antigen A or B.
So which means that we should reverse the answer then, right?
Yes.
We should reverse the answer, right?
Mm-hmm.
Okay. So the answer should be that because this, the group blood type A, they have this antigen.
Mm-hmm.
This patient can receive this RBC because it doesn't have any antigen. That's why the O blood type is universal donors.
Okay.
Right? This patient has, remember that the presence of, so this is the patient. Let's just focus on one patient. That would make more sense. If we focus on this patient, this is what we have in their blood. We have anti-B antibody. And the anti-B, this is the immunoglobulin, is going to react to the antigen. If we have have both antigens, AB has both antigens, right? So this patient blood is going to react definitely to this one and this one, because B has B antigen and AB has both antigens. So this patient's blood, if we give them this one, then their antibodies will attack the RBCs because it has B antigen. And also the same thing, if they receive the AB, that will also result in attacking this RBC because it has both antigens, at least because it has a B antibody that will attack the B antigen. And AB has both A and B. So that's why the blood type A should not receive blood type B nor blood type AB. They can only receive O or their own, right, type. They can receive A and they can receive O. These are the only options for them. Now for the RH, if they are RH negative, they can receive only A negative and they can receive O negative. They cannot receive positive because their own cells, it has another antigen. It doesn't have that antigen is not there. That's why it's negative. The RH is negative. But when the RH is positive, then they have a specific antigen, then they can receive positive and negative because their body is not going, or immune system is not going to elicit any reaction against the negative or the positive because their own cells, it's positive. So let's focus on the one more time because we have few minutes left just to review the blood type and the transfusion and make sure that you grasp the concept. So first of all, let's focus just on blood type A, and you can apply to B, A, B, and O. So the patient blood type A has the RBCs on the top of the cells. It has antigen of type A, and in the blood and the plasma we have antibodies, immunoglobulins type anti-B antibodies. So these anti-B antibodies definitely is going to attack the B, right? If your patient receives B or AB, because it has that antigen, it's going to attack them. Same thing for for blood type B. They have the RBCs has antigen B, then and in the blood plasma they have anti-B antibody. Because if they have anti-A antibody, then it will definitely attack any red blood cells which has A antigen on the top of the cell. So will attack blood type A if the patient, if let's say that you made a mistake and you made an error that this patient you brought the this blood type A to the patient to be transfused, then automatically you will see a transfusion reaction in response to this because their blood has anti-A antibodies going to attack this RBC because it has A antigen, and same thing will happen with AB because the cell also has A antigens. So the yes, questions. So in the middle here we have a patient who is AB, blood group or blood type AB. They have two different types of antigens, but they don't have in their blood. They don't have any antibodies. Can you mute if you're not talking? Can you mute please? So they don't have any antibodies in their blood, like in the plasma. So which means that they can receive any blood type or blood group, because in their plasma, their blood doesn't have any antibodies that going to attack anyone or any blood group or any cells or any RBCs, regardless if it has A antigen or B antigen, or because we said AB is the universal recipient, so they can receive any blood type or group because they don't have any antibodies to attack them. And then the last one is the O. RBC doesn't have any antigen, but it has both A and B anti-A and anti-B antibodies, which means the people with O blood type, they cannot receive any of these because it has antigens, A or B. And this patient has both of them or antibodies against both of them. So if you give them this, they already have antibodies that will attack them. Same thing for A, same thing for B. So this patient or this individual with blood type O, they can only receive O, but they can give anyone because they don't have antigens. Do you have any questions?